Afternoon, everybody. Today we are here to talk about end-of-life issues, and here with us would be Professor Virapon. First, let me just make a few opening remarks. Right, I think end-of-life issues matter to all of us, so long as we are living things. Right, whether you are a lion or tiger or whatever, right, it is relevant to you and to them. I was just, I used to watch a lot of National Geographic, and one of the things I noticed is that in the Lion Kingdom, right? The old lion, uh, before he ended up dying and dead, right? He usually lose his pride. I mean, the pride of lioness and cubs, and then he'll be alone trying to defend himself. And eventually, he got sick, or maybe he couldn't hunt for himself, and eventually he'll die. Okay, so the process of dying is actually quite long. Unfortunately, even for the lion, Um, but at the same time, I also think of one of our very dear colleague, Professor Henry. I'm sure Eileen, you know her, right? I think she lived to a good ripe old age of about 90 some. And according to a newspaper that you read, right, I think she was reading the paper in the morning and then having breakfast, and she just passed away. So apparently, it was quite quick and easy. And I'm sure we all like to be in that kind of situation, right? Uh, so anyway, I also hear that, a lot of people say that life is short, right? Well, I don't think so, actually, because if you are sort of towards the end of your life and experiencing the sort of unhealthy life expectancy, right? The last 10 years, it could be quite long and dreary rather than short, okay? So I'm sure all of us are interested in how to deal with this in a way that will allow us, all of us, to have a beautiful ending. All right. So with those words, I would like to pass over to Bin, who will share with us, probably from the perspective of economists, but I'm sure it'll be sort of interdisciplinary or multidisciplinary, right? You can't talk about end of life just from purely from economics perspective. So over to you, Min.
Thank you, Professor Tan, for that kind introduction. My name is Nopphol WITVORAPONG, and I also go by Mink. That's why I've asked Professor Tan to call me Mink instead, because Nopphol WITVORAPONG is a mouthful. So let me first of all give a bit of a background on this study. This study was commissioned by Kuntai Sijutsun, Kuntai 4.0, which is one of the research clusters under the National Research Council of Thailand. The project was completed exactly this time last year, and I'm now doing a separate project for them right now, a follow-up project for them, and basically trying to evaluate the impact of subjective death probability on different consumer behaviors. And we've just finished collecting the data for that project. But for the study that we're looking at today, that I'm going to talk about today, what I set out to do was to assess the feasibility of different end-of-life options in the context of Thailand. The focus would be on euthanasia laws that would be applied to people with terminal illnesses. And sometimes we call them end-of-life patients. And when we talk about end-of-life patients, we don't think about patients who are actually going to be dying very soon. We think about people who might live for the next 12 months, for example. So people who know that they're going to die, but their death it's not going to be immediate or very imminent. So just allow me to provide you with a quick analytical framework and a brief description of the methodology. The analytical framework that I used for the study was one of policy analysis. So we looked at the policy process, and we also looked at different components of a successful policy. So we basically looked at technical feasibility, economic feasibility, administrative ease, and political feasibility as well. And we used that framework for our case study investigation. We looked particularly at two countries with euthanasia laws. The first one was the Netherlands, which passed the euthanasia laws in 2002. And the second country was Canada with euthanasia laws in 2016, I think. And altogether, we reviewed 101 studies and supplemented those studies with 29 online data sources, including the World Value Surveys, LGBT International, and Economist Intelligence Unit reports and national surveys. So first thing we did was to try to think about how we would conceptualize the dying process and ask if there is a choice in the dying process at all. And this is where the economist comes in, because when you talk about economists in general, if we don't have a choice, that's not part of economics. With economics, we also think about choices and how we would make the best choices for ourselves and for everyone else if we care about them. So of course, if you look at the literature, there's not a lot of literature in economics about deaths. There's one paper in AEA proceedings about technology, but that's probably about it. Most studies on deaths and the dying process are based on anthropology, sociology, and also medical sciences. But in the sociology, anthropology literature, what they try to do, and I know Professor Tan is a sociologist, so maybe you can sort of back me up on this or tell me otherwise. But in the sociology literature, what they try to do is to try to separate deaths into two broad categories. The first one is unnatural deaths. This is when we do not have a choice in the dying process. Unnatural deaths are basically deaths that are sudden and caused by things that are unexpected, like accidents or natural disasters. And on the other hand, you have natural deaths, quote unquote, natural deaths, which is basically death from sickness and old age. And of course, with natural deaths, you do have a choice. The choice is that you have a threefold. You can actually either die at the natural pace, quote unquote, and we don't actually know what the natural pace is, and no one knows when they're going to die, but let's say that there's actually that natural pace that we're talking about. And we can actually die earlier than the natural pace, or we can die later than the natural pace. When we try to die earlier than the natural pace, that's called death hastening. And this is where euthanasia comes in. And if you want to die a little bit later than your natural term of death, then that's called death prolonging, or the term in the literature is dystonasia. Of course, we're going to focus particularly on the death hastening and dying at a natural pace. And we're going to ignore completely death prolonging because there's not a lot of policy angle to that. With death prolonging, there's actually a bunch of literature on immortality and cryonics, but we don't have time to talk about that first of all. And there's not a lot of policy angle because immortality is very expensive. And not a lot of people can afford that. So it's a choice for a handful of people, but not for the masses. So when we think about choices, we also then have to ask whether the state plays a role in those choices as well, and whether death management is something that the state should care about. And there's several arguments for this actually. And in economics, we sometimes think of the government as the benevolent planner who would try to maximize social welfare. And they can do that by assuming a bunch of different responsibilities. So first of all, what the government could try to do is to ensure that whatever policies they produce would correspond to social values. Because you would want to live in a state where the overriding social value is consistent with yours. Yeah? And of course, globally, social values tend to be more liberal and people are more tolerant of the freedom of personal choice, including when and how one should die. And that's where the state come in because they probably need to to be responsive to the shift in social values in that regard. The state also has a responsibility to define rights to avoid conflicts. And the right to die is an important right because it's really central to the conflict, especially between families of dying patients and medical personnel. People who want to die, they would need to have their rights honored. And also there's a cost element to this. Prolonging deaths is really expensive and wasteful. And it also takes away from the resources that could be spent on prolonging lives as well. If you look at all of these responsibilities that states have and put it in the social welfare perspective, you'll find that there's actually a role for the state to play in the decision to die for the people. So how exactly do states intervene? So what exactly do they do in order to manage deaths in the dying process? The literature basically provides, says that there are 6 end-of-life options currently. There are actually more sort of subsets of all of these options, but I'm just going to talk about the broad categories here. So the first 2 options, euthanasia and physician-assisted suicide, they are different forms of life termination on request. Here, physicians basically prepare lethal drugs. And in the case of euthanasia, the physician would be the one administering the drug. But in the case of physician-assisted suicide, the patient would be the one administering the drug. And the result in both cases would be immediate deaths. Yeah? They're legal only in some countries, not all. So countries like the Netherlands and Belgium and Canada, these options are legal. The third option is non-treatment. With non-treatment, this is when patients withhold or withdraw treatment that to sustain life. This is to prevent living or suffering too long. So if patients are conscious and they're able to communicate, this option is very easy to take. So all you have to do is to tell the doctor that you don't want the treatment anymore, you just go home. Yeah, and you could go one step further and not take food or water and then die quicker than you probably should. But most of the time, we know that dying patients are not able to tell us what they want. And certainly a law is required in order to allow people to have their wishes honored. And then that sort of law would be an advance directive law. So you would have a legal document, which is known as advance directives or living wills. And this legal document would then be used for medical doctors as well as your families to decide what they should do to you in the case where you're no longer of a sound mind and cannot make decisions for yourself when you're about to die. Yeah, so of course, with non-treatment, you don't die immediately, you will die at a natural pace. I couldn't really find information on whether non-treatment or advance directive laws are available in all countries, but I would imagine that they're available in most countries. And I think they are available in Singapore as well. There's a 1996 law in Singapore about advance directives, and this law is also available in Thailand, but we do have that law in 2007. The fourth option is palliative care. Palliative care is not a disease-directed treatment. It's a course of action to improve quality of life and to alleviate pain. And the idea is to try to make sure that people die at a natural pace with minimum possible pain. This is, of course, legal in every country. The last 2 options are life-terminating acts without explicit request from the patient and suicide. The former refers to the fact that sometimes physicians just kill their patients out of kindness. So they see patients suffering and they basically just put an end to it. This is, of course, criminal, not legal in any country at all. And but it's a phenomenon that's really well documented in the Netherlands and Belgium. if you look at the literature on end-of-life care, you'll find that some percentage, I don't remember what, but some percentage of medical doctors have admitted to having killed their patients because they know that the patients can no longer live with a good quality of life, and then they willingly do that. So if you look at all of these options, of course, I'm going to strike the last two out because there's not a lot of policy angle to it. And if you look at the remaining four options, palliative care should be considered a default option, because if you do absolutely nothing, you should get palliative care, right? And of course, people have no absolute rights to euthanasia and physician-assisted suicide. That's not guaranteed, even in countries where there are laws for those options, and non-treatment decisions might not fare well with some family members. And sometimes, especially in Thailand, there are cases where family members, even family members of dying patients with a living will, would not accept the living will because well, they just can't handle it emotionally, right? So we'll ignore the last two options and we think of palliative care as a default. And this is important for us to think about the default because moving forward, we also need to think about why is it that palliative care isn't adequate as an option for end of life? Why is it that we need to think about euthanasia? We need to think about non-treatment. We need to think about PAS. This table provides us with sort of a selected sample of countries with end-of-life options. So you can see that these countries, we can actually divide them into three different groups. So the first group consisting of the Netherlands and Canada and Belgium, for example, euthanasia, physician-assisted suicide, and non-treatment options, they're all legal. And then you have countries like Switzerland and the US. And in the US, there are only 10 states where what I'm about to say applies. In Switzerland and the US, euthanasia is not legal, but physician-assisted suicide is legal. And non-treatment options are, of course, legal. And then you have countries like the UK, Australia, Greece, where euthanasia and PAS are not legal at all. Only non-treatment is legal. The distinction between these groups is a subject of debate in the literature, and much of it involves ethical acceptability of all these options. I mean, of course, some people argue that PAS is different from euthanasia and non-treatment is different from the other two. But that we're not going to discuss the ethical aspects here because I want to focus a little bit more on the policy process. There's something that's interesting about Thailand, and this is something that not a lot of people talk about. In Thailand, euthanasia is definitely illegal. Non-treatment is legal, but in Thailand, what's interesting is the legal angle on PAS. In Thailand, suicide is not illegal, meaning that if you try to commit suicide and you do not die, you are not going to be criminally charged. There's nothing that the government can do to you because you're trying to take your own lives. So assisting people in the process of suicide, by extension, is also not illegal, which would suggest that when physicians try to assist patients in their dying process, they shouldn't be criminally charged as well. But this part is not really well debated in the country, and I'm not exactly sure why, because it seems like a loophole where you can just simply ask your doctors to help you die. Yeah, so, but anyway, so now we move on to the literature and think about lessons that we can draw from the literature and how those lessons apply to Thailand. If we look at the literature on end-of-life decisions, there are basically four groups. The first group of studies is about attitudes and acceptance of euthanasia and euthanasia laws. These studies are based on countries where euthanasia is legalized and where euthanasia is not legalized. And they also have different samples. They can actually ask medical personnel, or they can ask the general public. There is a study that I want to talk about, which is Cohen et al. In 2012. In that study, the authors basically used data from the European value survey. And they looked at that particular survey asked the question whether people find euthanasia justifiable on a scale of 1 to 10, 1 being the lowest, 10 being the highest. And the average level of euthanasia acceptance in Europe in general was actually quite high. It was over 5 in all the countries in the study. And in that paper, they found that religiosity was basically the most important factor of euthanasia acceptance. If people were religious, they would be more likely to be opposed to euthanasia in general. And at the country level, that study also found that societies that are more liberal or having a higher level of acceptance for the freedom of personal choice, people in those countries were more likely to accept euthanasia as well. So when we talk about liberal societies, empirically speaking, we look at whether or not people are accepting of abortion, whether or not people are accepting of LGBT rights, etc. So those are operational definitions that were used in the Cohen et al. Study in 2012 as well. All right. The second group of studies that are available is related to end-of-life practices. Again, these studies are conducted in both countries where euthanasia is legalized, and both countries and countries where it's not. Here, most studies found that physicians have at one point been asked to end their patients' lives in countries, in both countries where euthanasia is legalized and when it's not, and where it's not. Common characteristics of people who've requested medicalized killings are male. They're older than the general public, and they're better educated. And the number one reason why people want to hasten death is lack of autonomy, or control the bodily function. So when you are functionally dependent, you're more likely to want to end your life earlier. These groups of studies also consider changes in the number of euthanasia requests before and after the law, and most of these studies are conducted in the Netherlands. And the results are really mixed, actually. But regardless, in the Netherlands, surprisingly, if you look at data from death certificates, in 2005, only about 7% of terminal patients requested euthanasia, and only about 20% of them received it. So the percentage wasn't as high as what at least I expected. The third group of studies is related to debates on medical ethics and religion. And of course, we try to stay away from that here, but I just want to point out that there's a lot of papers on medical ethics and the impact of religion, and whether or not euthanasia is consistent with the religious doctrine of the sanctity of life. The fourth group of studies is related to debate about the appropriateness of euthanasia laws. So scholars who agree with euthanasia typically use the autonomy argument. They would say that if people are rational, if they're well-informed, and if they make their decisions voluntarily, then the state should really try to accommodate the decisions to accelerate death. But at the same time, there are concerns about the vulnerable, disabled people and the elderly, for example, who might be pressured into ending their lives sooner than they would probably prefer. There are also concerns about the physician-patient relationship, because euthanasia laws have the potential to commercialize that relationship, because physicians now benefit financially from patient deaths. And that could lead to distrust within the medical system. That could also lead to, could make doctors being desensitized to patient deaths, and they might not put a lot of efforts into medical treatment for non-dying patients. And there are also concerns about the number of euthanasia requests, meaning that it's possible that once we have euthanasia laws, the number of requests would be much higher. So a lot of people would think casually, too casually about deaths, in which case we have a society filled with deaths that are probably not necessary. And the final concern is related to the impact of euthanasia laws on palliative care development. Because palliative care would become a less attractive option if people can choose not to suffer at all and die once they know that they're going to die pretty soon anyway. And of course, these concerns are empirical questions. You have studies that basically suggest that these concerns are legitimate, and you also have studies that suggest that these concerns are completely unfounded empirically. So there's a debate that's still ongoing with the appropriateness of euthanasia laws. Now let's look at the case studies. So as I said earlier, in this study, I looked at the historical experiences of both the Netherlands and Canada, but we don't have time to talk about both of them. So I'm just going to focus on the Netherlands. Yeah, with the Netherlands, the euthanasia law was termination of life on request and assisted suicide act in 2002. In the Netherlands, in order for the actions of euthanasia and physician-assisted suicide to be considered legal, the following criteria would have to be observed. So the patient request must be voluntary and well considered. There has to be a way for the physician to know that the patient is making the request voluntarily. The patient's suffering must be unbearable and hopeless. The patient would have to be informed about the situation and his prospects of getting better or getting worse. There must be no other reasonable alternatives. The physician who is going to perform euthanasia would have to consult another independent physician as well. And the termination of life should be performed with what they call due medical care. What that means is that the physician would have to be with the patient throughout the entire process. You can't just leave the patient. Behind and then have them die by themselves. See, there's also another criterion that's important, but it's not part of the law. In the Netherlands, they also set up a review committee consisting of an ethicist, a medical doctor, and a lawyer. And basically what they do is they review euthanasia cases, and then they see whether or not those euthanasia cases conform to all these criteria. So you can see that these criteria, as well as the establishment of the review board, basically they act as safeguard measures against all the concerns that we discussed in the earlier two slides about the appropriateness of euthanasia law. So it's important for any country considering euthanasia laws to think about all of these criteria as well. And let me point out very quickly that these criteria and the criteria that they use in Canada are slightly different. The age group is different. In the Netherlands, people who request euthanasia can be as young as 12. In Canada, it's the age is basically from 18 years old onwards. From the policy standpoint, you can see that euthanasia law is very feasible in the Netherlands. First of all, there's not a lot of technical expertise involved in killing patients, basically. So all you have to do is to make sure that you prepare the right dosage for lethal drugs and then and administer it correctly. it's also, the law is also financially feasible. There's low cost to the public health system because private insurance companies in the Netherlands basically agree to cover euthanasia. Administratively, the implementation of euthanasia laws in the Netherlands isn't particularly difficult. In the Netherlands, they have a really strong primary healthcare system. And what they do have is a strong network of family physicians or home physicians. And these family physicians, they provide care to families throughout the life course. So they provide care to the father, the mother, all the kids in a particular family. And because of that strong physician-patient relationship, doctors are able to assess euthanasia needs properly and prevent the number of cases from going up too high. Yeah. Finally, from the policy standpoint, you'll find that euthanasia laws in the Netherlands is politically viable. The literature simply suggests that the public, all the physicians, medical associations, the justice systems, they all have a high level of euthanasia acceptance. So it's possible for the Netherlands to have the law. Now, we can further try to look at the case studies and identify factors that or components that are needed in order for us to have a successful euthanasia law. So if you look at this, you can find that in both the Netherlands and Canada, there was a long and extensive debate about euthanasia in both countries. In the Netherlands, for example, the debate actually took place from 1973 to 2002. So it was about 30 years. So they widely, extensively debated the appropriateness of euthanasia as a policy option for 30 years. In Canada, the debate took place from 1993 to 2016. So that was 20-something years. So certainly social dialogues are a requirement for a society to have euthanasia or to think about end of life options beyond palliative care. Second, in both countries, there was a shift in attitudes towards deaths among the public and among the physicians themselves. The physicians, they felt less negative about the dying process and about medical assistance in dying. And they understand that it's actually better to let go. And the public also, they have increased tolerance for the freedom of personal choice. You can see that when we talk about euthanasia laws, which is a really liberal law in and of itself, we think about the freedom of personal choice in parallel with the law, because it's quite similar to LGBT laws. It's quite similar to abortion laws in the sense that all of those laws allow people to freely choose their own course of action that's related to their own lives. Yeah. So in that sense, we know that there's that shift in terms of the attitude, but the shift itself isn't exogenous. If we think about it, in the Netherlands and Canada, both countries, they have a pretty strong palliative care system already. So in both countries, if we look at the quality, according to the quality of death index by the Economist Intelligence Unit, both countries ranked within top 15 in the world in terms of the strength of their palliative care system. And what that implies is that medical doctors, physicians, people, they all know that they have palliative care as a credible option for end of life. Yeah. So so the shift in the attitude isn't something that happens exogenously. It's endogenous. It's integrated in the system because people in the societies have actually thought about deaths and they have provided different options for death. And finally, in both Canada and the Netherlands, you'll find that there was a high level of political feasibility for euthanasia laws. And a lot of people, all of the stakeholders are on board with the idea of medical assistance in dying. So to summarize, it's based on the literature and the case studies. we can find that for a country to stand a chance in having euthanasia laws at all, the following three components would have to be present. So first of all, there has to be some liberalism in the country, because euthanasia is such a liberal, such a liberal decision. There has to have been an extensive debate on euthanasia laws. The level of political feasibility would have to be high. Yeah, so at least these three components would have to be present. Right. So let's now consider Thailand. In Thailand, the current options for end-of-life, options in Thailand are twofold. So we do have non-treatment decisions provided under the National Healthcare Act in 2007, and we do have palliative care. We, of course, euthanasia is not legal in the country at the moment. Physician-assisted suicide is, well, it's neither legal nor illegal. So the obvious options in Thailand are only palliative care and non-treatment. This suggests that people are, it suggests that the state has a preference towards people dying at a natural pace. So of course the state clearly provide no options to hasten death legally. But I argued in the city that that might have to change, and the Thai government probably needs to care a little bit more about death hastening options, and there are a number of reasons why. First of all, in Thailand, among the top 10 causes of death, 8 of them are NCDs, including COPD, stroke, etc. And NCDs account for at least 50% of deaths in the country. And with rising life expectancy, this tells us that deaths among Thai people are actually a slow process. People are not going to die suddenly. They're going to die slowly, and presumably the quality of life before they die is not going to be very high with the presence of NCDs. Also in Thailand, there's an ongoing demographic transition toward a completely aged society. About 18% to 20%, well, I say 14 to 18, that number is wrong. 18 to 20% of the current population is older, 60 plus, yeah? And the total fertility rate is 1.5. The demographic transition here is really important because, first of all, Thailand doesn't really have a comprehensive long-term care system. There is an access demand for institutional homes in the country right now. Second, old age in Thailand is linked with poverty. The average poverty rate among older people in comparison to the general public is much higher, almost twice as high. Third, we see in the literature, not just in Thailand, but elsewhere, that the number one reason for people to want to die is lack of functional independence. So for those reasons, it's important to understand that the demographic transition here implies that older people who are functionally dependent and probably the most likely candidates of euthanasia, they're not going to be able to rely on the government for long-term care. They're also not going to be able to afford private nursing homes in the market. And they're going to be much less likely to be able to rely on the family because the family size would shrink too much in the future. So the demand for death acceleration is expected to be high if nothing structural is changed. We also find that the healthcare expenses are high within the last 3 and 1 years of life. They account for about 25% and 11% of total health expenditures in the country globally. So prolonging deaths is really expensive, or even allowing people to die at a natural pace is expensive. And finally, social expectations are changing in Thai society. Thai people are much more likely now to be open to the idea of the freedom of personal choice. So we have the 2016 abortion law now, and we also have the 2020 civil partnership law, allowing same-sex partnerships to be legally recognized. There's still a long way to go, but I think it's a natural trajectory to think that rights might also be given to dying patients in the future as well.
Min, could you wrap up quite soon?
Oh yeah, will do, sorry. Okay, so if you look at the supporting factors in Thailand, so as I said, there were 3 of them. Of course, in Thailand, we need to think about whether or not there's an existence of liberal democracy in the country, and apparently there's not, because we don't even have a full-fledged democracy yet. But what's interesting about Thailand is, unlike in Western societies where liberal democracy and the idea of social liberalism, they coexist, in Thailand, they do not technically coexist. We don't have a liberal democracy in Thailand. But what we do have is increased tolerance of the freedom of personal choice, which is a form of liberalism in and of itself. So Thai people are much more accepting of, for example, gays, abortions, and the sexual discourses in the country are much more open now. If you look at the second supporting factor, which is the extensive debate on euthanasia law in Thailand, you'll find that there hasn't been a lot of debate on euthanasia law. The debate was sparked in March of 2019, and that was the first time the public even heard about euthanasia in the country. It was there was this, of course I didn't put up the Facebook page, but there was this gentleman who posted on his personal Facebook page that he would be traveling to Switzerland to get medical aid in dying. And his post was reproduced so many times, and it became a focus on different news channels, and it was reproduced until September 2019, basically. But after that, there was definitely no discussion euthanasia in the country. And if we looked at Google Trends, we find that there's no search activities from September 2019 onwards until today. So it's clear that the debate is really temporary in the country. Third, we find that in Thailand, the public certainly supports euthanasia. In the survey that I was talking about, that I said I just finished collected for my other project, in that survey, I asked whether or not people agree with euthanasia, and about 40% of people who actually knew anything about euthanasia at all said they agree with euthanasia, and they actually want euthanasia to be implemented in the country. But we don't get the same support with opinion leaders. Medical doctors, with the Ministry of Public Health, for example, they don't care for euthanasia at all. And they want people to stick with the non-treatment decision and right living wills. Yet political leaders are completely, they're absent from the scene. We don't know their opinions at all. So in terms of the implication for Thailand, in the long run, obviously, we might actually have to think about euthanasia in the future because of the demographic transition and the value transitions I've just described. We also need to think about the design of the implementation of euthanasia laws as well. So we need to know whether or not medical professionals are going to partake in the process. And if they do not partake, then certainly the euthanasia laws cannot be implemented. We need to also think about safeguard measures to make sure that people are protected properly. And we need to also think about resources to enforce the law. In the short to medium term, however, now that we do not have euthanasia, we do not have physician-assisted suicide, what we do have is palliative care and non-treatment. So it's important for us to make sure that the palliative care is an attractive option in the future. Right now, in Thailand ranks number 44 in the world in terms of the development of the palliative care system. So there's still room to grow. In terms of the advanced directive law in Thailand, it's been effective since 2007, but a really low percentage of people actually took up the law. And then a lot of people just didn't even know what advanced directives are. And of course, social dialogues are important if we want to talk about different options for death, because we don't want people making ill-informed decisions. So that's the end of my talk. And I think I went over slightly. Sorry, I rushed to the end. Thank you, Dr. Tan.
Okay. Min, could you stop share now? Yeah, thank you.
Yeah, certainly will do.
Okay, I think my assessment of Min's presentation is that there's a lot of sociology there. Not to worry, so so from that perspective, you pass. Okay, let me begin with one question, and then we open it to the house, right? I mean, basically, my question is that it's about the family. What's the role of the family in this? And you know that among Chinese, right, one of our values, cultural values, is that of filial piety, right? Do you think filial piety come in the way of making a decision about euthanasia somehow, somewhere? Yeah, and okay, after this, you open to the house, yeah.
All right, thank you. Yeah, the family plays an important role. There's a all right. There's actually a disconnect between the literature based on Western societies and the literature in non-Western societies. Filial piety is basically a concept that we as Asians understand quite well. But filial piety, on the other hand, in Western society is a concept that's not really recognized a lot in the literature in Western societies. And you have to understand that with euthanasia laws and euthanasia discussions, the literature is predominantly based on Western societies. But if you look at studies in Thailand where we do discuss non-treatment decisions, families play a huge role in non-treatment decisions. And there's actually a study, I don't remember who by, but it was basically published in 2015. That study clearly said that even though dying patients wish to end their lives sooner, and they even wrote a living will to make sure that they wouldn't get the treatment to sustain their lives, the families still did not honor the living will because they felt that it was their duty to make sure that their parents lived. I call this immediate and convenient filial piety, meaning that you never really take care of your parents when they're capable of taking care of themselves, and then all of a sudden when they're about to die, you start caring about the death of the parents, and which is really a contradictory statement in and of itself. So that's my answer. I don't know if I've answered your question. But
no, I think that's good enough. Questions from the audience? Okay, Aileen, you have a question, Aileen?
Yes, actually a couple of questions. Thank you very much, Min, for your presentation. I probably didn't catch very clearly. Is Thailand preparing the ground for euthanasia law, or has it not come about yet? You said that there's not much debate. So is there much thinking about passing a law? If there's none, then I mean, what is your worry? What is your whole presentation about? That in Thailand there's not much support for this law, so why we worry about it? Why we discuss it? The second question is that in considering the change of attitudes of the public, including the healthcare professions, in many countries previously, the physicians can make some decision about whether to end treatment or not. Even in Singapore, for example, there's an unspoken practice among hospital doctors that under certain conditions, you do not resuscitate the patient. Of course, now you consult the family, but in the past, I think they make a decision based on medical criteria, based on how likely is the patient to recover and so on. But beyond that, in modern world, I think there is a big role for defensive, for the factor of insurance, health insurance. If you say that euthanasia is covered even in insurance in the Netherlands, or insurance covers all kinds of illnesses and prolonging of life by treatment, then I think this really impact on the decision of physicians, on the decision of the individual, and so on. So this factor you have not counted into your calculation of the costs and benefits of euthanasia or prolonging life. Of course, doctors now practice defensive medicine, and given the fact that insurance does cover the prolonging of life, then I think people's decision to end their life is actually impacted by all these external factors also. But please, can you clarify what is the position of Thailand? Why are you worried about euthanasia if there's no public opinion in support of it?
Right. Thank you for your questions. Actually, we don't have euthanasia laws yet, as I said. I'm not particularly well. This project was basically based on based on concerns by Thai scholars as to whether we should prepare for euthanasia in the future. Okay? So what I did was to basically try to gather available evidence to see whether or not it was possible or it would be possible for us to have euthanasia in the future. I looked at all these different components and in order to try to come up with a preliminary evaluation of the feasibility of euthanasia laws. There's also another question that you asked, you were talking about palliative care as you were talking about palliative care and the DNR decision. Palliative care and DNR decision, they basically go hand in hand. When we talk about non-treatment decisions and we talk about palliative care, the distinction between the two isn't really completely distinct. There's some overlaps between the two. When we think about non-treatment in and of itself could actually be a form of good palliative care. Doctors, they do not always have to treat patients. They could also make a suggestion that, you know, it's probably better for you to not have any treatment at all. So you're right, non-treatment is part of palliative care. You're also right to point out that health insurance, if it covers euthanasia, that would have a clear impact on opinions of people towards euthanasia. With euthanasia in Thailand, though, and there's again, I sort of rushed through the end of my presentation. So what I wanted to say in the presentation was this: there was a lot of interest on euthanasia in Thailand. The interest, however, wasn't really sustained. There was a lot of interest for a brief period of time. But because no one actually led the discussion in the country, and the discussions in the country were quite frankly ill-informed. So there wasn't really a study on euthanasia in Thailand before this one that I've just presented. So I guess my role was to basically fill the knowledge gap and then to make sure that we open social dialogues in the future about euthanasia so that people understand the pros and the cons, and then they also understand whether or not they would want to have euthanasia in the future, given the interest in the media.
Okay. There's another question, I mean, from Bunwara. Yeah? Bunwara? Go ahead, please. Ask your question.
Yes, thank you. Hi, Mint. I really enjoy your presentation, especially the part when you pointed out that the Netherlands and Canada, which both countries already have quite effective palliative care system. In Thailand, we are at least for what I have been informed, we are trying to reform the palliative care system because right now it's very, very expensive. And that's why euthanasia is an alternative that we are looking now. So I'm just wondering if you could add a little bit more information on what makes the system, the palliative care systems in Canada and the Netherlands work. What would be the key points, the key factors that make this system works in Thailand as well?
Okay, thank you. Well, palliative care is usually based, in order for you to have a good palliative care system, you need to have a really strong primary healthcare system. because palliative care in and of itself is based a lot on primary care. And palliative care is palliative care involves not only medical doctors, but an interdisciplinary team. So you typically need to have a strong group of nurses, a strong group of people in communities who basically provide social and spiritual support as well. And in Canada and the Netherlands, if I understand their systems correctly, what they do have is they have a system of family medicine. So they have doctors who take care of a group of families. And those doctors stay with the family throughout the entire course of their lives. Doctors, if they have a strong relationship with their patients and the relationships are personal, then palliative care is sort of an extension of that. In Thailand, though, we don't really have family doctors. We do have family medicine and people who basically talk to some families on a regular basis, but we don't have family doctors. What we do have is a system that's treatment-based rather than prevention-based. People, when they get sick, they go to the hospitals instead of going directly to the family doctors. And palliative care, therefore, in Thailand, is based on the hospital system. And with that, it's really difficult to expand it. So we need to rethink the concept of palliative care in the country first, before we even discuss the options of euthanasia, etc. Because we want to make sure that palliative care is a viable option, and that people, if they know they're about to die, they can credibly rely on palliative care. I hope that answers your question.
Okay, I think we have time for one short question with a short answer. Could you do that? Aileen, go ahead.
Okay, this is a short question, but a very long answer for you if you want. What is the role of the religious leaders? I mean, for the Buddhism, it's very obvious. You know, all these liberal countries, Christianity isn't any more a major force in people's decision or individual rights and so on. How about Buddhism in Thailand? I mean, don't they speak up on this issue?
They do actually, and they don't like it very much. so that's a short answer for you. If you look, and this is interesting actually. Even among Buddhist monks themselves in Thailand, they have different views on this, because in Buddhism, when we think about taking one's own life, that's basically against the principles of Buddhism, right? But there's actually some exceptions. If you look at the literature, there are some exceptions. There are cases where in the past, during when the Buddha was still alive, there were two cases. I don't remember the names actually, but they're part of the study as well. But I didn't prepare for that. But there were basically two cases where the two monks there, they took their own lives, and the action of taking their own lives there wasn't against the principle of Buddhism, because the taking of life wasn't based on any malicious intent, if that makes sense. But anyway, in the popular media in Thailand right now, if you look at the popular media, Buddhist monks that are vocal about euthanasia, they basically against the idea, because they don't want people to think too casually about deaths, and they don't want people to just basically, try to take their own lives.
Okay, thank you. Because
Okay.
I'm wondering about Muslim countries. I mean, will euthanasia ever become a law in Muslim countries, you see? Yeah.
I think that would be very difficult.
Okay, maybe we hand over to Poop, and then is there a question, or you want to wrap out the seminar?
No, actually question. I hope you wrap up the
Okay.
seminar. My question is short. I'm just curious, expanding end-of-life options seems to be, from economics perspective, it seems to be something that the government of Thailand would want to support, right? Given that, the universal healthcare burdensome for the government, and expanding options, palliative care, euthanasia, that seems to be one of the arguments that, I mean, whoever would want to support this can consider. I mean, I just like to hear your takes on it. Thank you.
Yeah, you're right, but I think when we think about social policies, and especially social policies that are in relation to medicine, we sort of need to understand that the power structure in Thailand is one that's based on the idea of medicalization, meaning that policies are informed by medical doctors. If you can't get medical doctors to be on board with euthanasia, then it's unlikely that it would become law. And it's actually, having medical doctors on board is one of the strongest preconditions for euthanasia laws in any country at all. In Canada and in the Netherlands, for example, medical doctors are on board. And you can actually see evidence based on statements from medical associations of the Netherlands and medical associations of Canada that explicitly say that they find medical assistance in dying a good and humane option. And it's part of their duty of care because they want to make sure that that patients, they can die peacefully and with minimum pain.
Okay, I think we have to wrap up now. And so with that, let me thank Min for a very comprehensive, very clear presentation. I think we all learned a lot. Okay, at least I do. I'm sure the rest do as well. So we can put our hands together and thank him.
Thank you very much.
Thank you very much.
Yeah.
Bye-bye.